We're here at the ESMO meeting, the European Cancer Congress in Vienna. Dr. McDermott is with me. Thank you very much for being with me. You have a poster about Pembrolizumab and Pazopanib in combination. Pembrolizumab is a new immune checkpoint inhibitor. Can you tell me about your results from that abstract?
So this has been an interesting meeting for us and for our patients. Lots of new data for patients with kidney cancer. One of the biggest news stories is the activity of PD-1 blockade in patients with kidney cancer. Nivolumab, which is similar to Pembrolizumab, released its results of a large phase 3 trial that showed it to be superior to an old treatment, Afinitor, for patients who'd failed prior TKI therapy. So that likely means there'll be a new option for patients, a new form of targeted immune therapy for our patients once they've had prior treatment. There's also another study with a new TKI called Cabozantinib, which has also shown superiority to patients who are receiving, compared to Afinitor in patients who had failed prior treatment. So now we have two new options. One question becomes, can we combine these approaches? Can we combine VEGF TKI therapies, of which there's so many, with immune therapies? And there are many different combination trials undergoing. We presented our results today with, as you mentioned, Pazopanib, which is also Votrient, which is a standard approved therapy for kidney cancer patients, and Pembrolizumab, which is very similar to Nivolumab, which will soon be available for patients with kidney cancer. And what we found is when you give these drugs together, there seem to be significant side effects at the full dose of Pazopanib, but also at lower doses. So this becomes a question. Can you give these drugs safely together? We know you can give one and then the other, but at the same time, it might be an issue for patients, particularly with liver inflammation. And the patients recovered from the side effects when we held the treatment, which is good. Some patients required steroids to decrease the inflammation, but when we reintroduced the treatment, the side effects returned. So we need to do a lot more work finding new schedules, new doses, new ways of giving these treatments together. It may turn out that Pazopanib can't be given safely with these new immune therapies, and other treatments that are available for kidney cancers can. Those trials are underway, so this isn't the only trial. But for patients who are on Pazopanib or Votrient and they're having liver inflammation, if they then want to switch to PD-1, we need to be careful with those patients. We need to make sure the liver inflammation resolves before we start immune therapy. And that'll be important for both patients and, most importantly, for doctors to take into consideration that if you don't let the side effects resolve, sometimes the PD-1 blockade can make those side effects worse.
Wow, these are like really big news, and these are very, there are implications for the patients.
Absolutely.
So what can we tell the patients now? How should, if they ask for a trial or for PD-1 after a TKI, what are they supposed to talk to their doctor about?
That's a great question. I mean, to me, the first question is, does it make sense for you as a second treatment? So they should ask their doctor, are there immune therapies available to them that make sense? And the answer in a few months might be yes, when Nivolumab becomes approved. But it won't be immediate. It may take several months. It may take a year or more in certain countries around the globe. So it's not going to be immediate. But there are options. So they should ask, what are my options? Do I have any new choices? But if they find out they do have a new choice, and that choice in their doctor's mind is immune therapy, they should also talk to them about, have my side effects resolved? And if the answer is no, they may not want to rush into immune therapy. They may want to pause, allow the side effects to resolve, which they do when you hold the treatments, but not always right away, not the next day. It may take several weeks or a couple of months for them to resolve. And I think that's an important lesson from this work we presented today.
We also have a lot of patients that are running a long time on a TKI. And before we always heard, if you have like a real long phase on a TKI, you should might as well stay or switch on another TKI. Yep. So how do you think now the paradigm is going to shift?
It's hard to know because the comparison here was immune therapy to mTOR inhibition, not immune therapy to TKIs. We really need more data on that question. But I think most of us will try a new approach as the second-line treatment. For example, most of the people who went on the nivolumab study had just failed one prior TKI, not two. So I think we'll try it, but for many patients it's not going to work. So we need other options, and we need to answer the important questions that you pose. We don't really know the answer to that question. For some patients, TKI1 and then TKI2 might be better than TKI1 and then PD-1 therapy. We'll have to see.
Mm-hmm. So you told me before that the combination Pembro and Pazo didn't do so well, for liver toxicity reasons. Do we have other TKIs in combination trials where we can also see that?
Well, there's not a lot of published information yet, but the trials are underway. So there are several trials. For example, Axitinib is in combination with a couple of these immune therapies. Bevacizumab or Avastin is, presented small amounts of data. It may turn out that there's some agents that are safer. We'll see, but we need a lot more information.
Thank you very much, Dr. McDermott. It's been a pleasure.
Thank
you.